this thing. We've got some new equipment that we're excited about. Our conflict of interest policy is this opportunity for each member to disclose potential conflicts and their belief that they can be unbiased and able to participate, or that they elect to recuse themselves from the matter. On our agenda, we do have our October minutes for approval. Are there any additions or corrections that we need to note? If not, we'll... It's been moved by Dr. Martin and proper second. All in favor, vote by the sign of aye.
Aye.
All opposed, ayes have it. We'll now move into our financial report for September.
Thank you, Mr. Chairman. The month of September was not as strong as the first 2 months of the year, but we did eke out a small operating margin profit. Our inpatient volume admissions were 207 versus a budget of 172, so down slightly from the prior month, but still a strong admission month. Our observation admissions, which is an area we've been working on with case management and utilization management to reduce the number of observation admits and increase the number of actual inpatient admits. So we're happy to see that our observation numbers dropped to 132 observation admits this month. That was after 202 and 192 the two prior months. So that's a significant drop. That's efforts of staff and also the hospitalist physicians working to convert patients before they get to 30 hours or 36 hours of observation care. But what it has done is it has reduced a little bit our length of stay, because the same focus is on my inpatient admits. So our total patient days are actually 12% below the budget, even though admissions were 20% above. And that's because the length of stay is 27% below or better than we had budgeted for the month. Let's see what else is relevant here. Emergency visits for the month, about 4.5% or 100 visits below the budget, and about 120 below last month emergency visits. We did have more emergency admissions in the month than we had budgeted, which is positive. Our clinic visits for the month dropped off about 700. Significant there, we had two physicians that were out on FEMLA in that period, and so their clinic visit numbers certainly went down accordingly. Both were surgeons. Also, you can see surgery inpatient cases at 35. We were right on the budget, a little ahead of last month at 32. But our outpatient surgeries did dip from 109 last month to just 90 this month, a little below the budget of 93. Again, I mentioned we had two, a general surgeon and ophthalmologist who were out with FEMLA and unable to practice that month. Cardiac cath lab was busy, and it's been busy the last couple of months, which is positive, but our deliveries, which have been up and down, they're down this month to 24, budget was 30, prior month was 33. Case mix was relatively steady, 1.44, last month was 1.39, and so those are sort of the high-level stats on the patient side for the month. And if there are no questions, I'll go into the financial statements. The revenues, inpatient revenues were about 12% below the budget. That lines up with the days. Patient days were about 12% below the budget. Outpatient revenue was 12% behind budget as well, consistent here. Our clinics were obviously behind about 600 visits. The observation visits, those actually fall into outpatient even though the patients are in a bed, so that affects outpatient revenue. And then our emergency department was down about 150 visits from the prior month. So that was the drivers for why our outpatient revenues were 12% behind budget. Net revenues at $3.95 million for the clinic, for the hospital net revenue collections, about $1,166,000 behind. So that's a pretty big miss, 22%. We had high bad debt this month, $3.9 million versus 2.5 budget. And so payer mix was part of it, and then obviously the gross rev factor. In our favor again, which I know this is the third month in a row, you remember we got a significantly higher payment from the state pool this year than we have in past, and so we're flushing that through the income statement. And so for this month, we had 3.2 plus million in essential access dollars, and that's about a $2 million favorable variance for the month. Our expense line, you can see there are a couple that sort of stand out. Our supply costs and pharmacy costs together were about $325 above budget for the month. And then repairs and maintenance in this older building that we have, $188,000 higher than budget. Those are the big negatives on cost. So total cost of $12.1 million for the month versus a budget of $11.7, and so a $400,000 negative variance there. But because we had the essential access revenue favorable of $2 million, we still ended up making almost $300,000 operating margin. Budget was to lose $200,000, so $500,000 positive variance. And for the year to date, through 3 months or through the first quarter, we have a profit of about $3.3 million, and we were budgeted to lose 2.7 in the first 3 months, so positive. And you probably know, I just mentioned it, I mentioned it to Metro on all calls, is we have paid capital and other things like that out of our operating funds through the first 3 months. We've been told we will have access to get reimbursed for some of the capital at Bordeaux and other areas, probably in January timeframe. So that will relieve a lot of pressure on cash if we can get access to that money. And we've been assured we will as soon as the surplus for the city is confirmed. So that is the first the September performance, and I'm happy to answer any questions.
Don't forget your mic there.
Yeah. Thank you. Bruce, these favorable revenues for other and essential access, will this continue in a prorated way across the fiscal year? So our favorable to budget operating margin will continue?
Unlikely to continue at that level. That was particular because the supplemental pool that we get from the state each year, July, we're just spreading it through the year. That one is being spread throughout the year. We get safety net dollars and essential access dollars from the state. They pay those 1/1 to 12/23. So after 1 of 24, I don't know what those numbers will be. So I think that they'll stay higher than what we have budgeted, but I can't say they'll stay at these levels. I just don't have a crystal ball, and there's no known algorithm as to why our numbers go up or down from year to year with those pool of funds. I wish I could tell you better, but it really is somewhat a surprise. And you understand, if we get significant dollars, then we won't have to draw money from Metro, typically. So if it continues, that would be great, but I would be surprised if it stayed at these levels through the full fiscal year.
Bruce, was it anything in particular that contributed to the lower numbers in terms of the emergency visits?
No, I still think we're still about 15-17% down in ED visits compared to pre-COVID. It's never really fully come back. So I really can't speak to it. I think we have a pretty good ER service here, so I don't think it's that. I know the facility is a little dated, and that's one of the capital items we want to address is the presentation of that ED to people that come in early in the ED. So that's one of the things we want to use some of the capital for. But I don't know. I do think we've got a consistent set of physicians that have worked there for many years, and I think they do a good job. And I think our nursing staff in there is good. And so I wish I could tell you I knew what it was. I don't. And we're now at trauma level 3 certified, and the fire department and EMS are aware of that, but it hasn't created additional volume yet that's tangible to me.
I have a question, Bruce. In regards to pharmacy and supplies, I see that we're a little bit higher than budget, not a whole lot, but a little bit higher. And I know during COVID, we would see that with pharmacy and contract labor. Are you seeing a downward trend for pharmacy and supplies?
We did have a downward trend in pharmacy. We had such a spike during COVID, it probably went up, pricing went up 50%, 60%. It sort of relaxed last year. And so what we see here, just typically we do inventories at the end of June. And so we leave accounts payable and all that sort of stuff open well past June 30th typically. And so my July is usually a little light because I didn't have enough purchasing activity, and we don't really accrue for that. So my first couple of months were probably a little light. This one's probably a little bit heavy, particularly in pharmacy where we've been running a little bit favorable. But, our pharmacy is driven a lot by oncology. Even though we're a small hospital, our oncology meds probably are 30% or more of our pharmacy costs. And it can be a couple of patients with some really expensive regimens, and it kicks that number. So what we're always looking at, I'm looking to see that there's basically a 3-to-1 charges for pharmacy versus what my expense is, because that's sort of the markup that we use in the inpatient and outpatient setting. So as long as I see that relationship, then I feel like the meds we're buying are being charged, and it just depends on whether the patient has a payer source or not as to whether we get paid for those.
When you're talking about clinics versus the ED, et cetera, I think we can look at the budget and we can, kind of track it month to month, year over year. But are we breaking these, let's say, subsets, different lines of business, for lack of a better term, within the hospital down that pulls out these influxes of cash that we can't control, by the state or by the city? Are we pulling those out and actually looking at what those departments are doing month to month, year to year, and the trend of that?
Are you talking about the revenues?
Yeah,
Christy?
yeah. So that's why I was, when you're saying that, I just did the math where you said, here's the budget, here's the actual 11.7 versus 2.1 plus the 2 million. So that puts us ahead. But if you take out the 2 million, you break it down by lines of business. My question is that, are you seeing year over year, month over month, a trend? Yeah. And I guess to me, that's the true representations of each of those lines of businesses, not how the hospital did as a whole. Because you have to back out those extraneous and random revenue sources, right?
If we didn't have the unusual sort of revenues or the excessive revenues in the first quarter, we'd have been pretty close to our budgeted loss. So those have really floated us through the first quarter. We have 77 departments, and every one of them sees their budget performance each month. But I don't drop that extra money into each department. It stays up at a top level because it's really not related to any particular department. So our other managers are looking at their departments versus what the budgeted plan was for volume, revenue, expenses, and they try to manage to that.
Right, and what I guess maybe I'm not clear, each of those departments, though, is what I'm asking is, are you seeing trends in certain departments like the emergency room that continues to lose money on an ongoing and regular basis, or let's say clinics continue to make money on an ongoing and regular basis, and are you identifying trends and or actionable steps by which you can either infuse dollars into, reappropriate dollars into, that would make a meaningful difference? I guess that's what I'm trying to say, looking at it as a line of business rather than an overall budget.
Yeah. Qualified response, I guess I would say the emergency department is down slightly. this year compared to last year. Last year was up about 4%. This year is down 4%. I'm not sure that we're going to change either the physician staffing or the nurse staffing yet. If it stays prolonged, yeah, because we have staffing standards that we use in every department. And if it stays at a reduced level, we would probably look to start reducing at least the nurse staff hours and so forth in those areas. But as far as the profitability, we don't bring net revenue down to the department level, even for, say, imaging. Imaging department produces a lot of revenue. Pharmacy produces a lot of revenue, but I don't get paid at the pharmacy level. I get paid at the total claim level. So I've never been in a hospital where I ever netted it down to the department level, where that probably analysis would make sense for us. But we do look at the volumes, and we do look at where their trends are in terms of volume. And, you know, we've seen some OR volumes that have been all over the place. L&D volumes, we've had 55 deliveries and we've had 24 deliveries. And so you have to work with an average. We have to do minimum staffing on the women's units up there in order to meet state staffing requirements. So with the staff we've got in L&D postpartum, we could deliver 125 babies. But minimum staffing requires us to have what we have. And if it's 30, our numbers are a lot worse than if they're 50 or 60. And almost every mom baby is a paying patient. So they're very rare that you have an uninsured patient delivering a child in the United States or Tennessee. So I don't know if I helped you much there. We don't bring net revenue down to the department level. It sits at the hospital level. And the same really with our clinics. I have revenue for each clinic, but I don't have net revenue for each clinic. So they do see their gross, they just don't see their net.
I was just thinking in terms of looking at it in terms of who might need more resources or who might need a little bit of a microscope on it to see if we need to make some changes, right? So if you're seeing a trend quarter over quarter, year over year, whatever that time frame that you feel is appropriate, knowing the healthcare industry, that might make sense to fine tune those. And or as we get these grants, oh, this has done really well. We need to plow more resources into that with the money that we have coming in, because we continue to see a need, one, and then two, we could even elevate that experience versus, oh, this is probably not working out so well, or maybe this is not needed as much. That's the reason I asked, not really as a function of like more trending.
Right,
I guess.
no, I get it. You know, the business plan for the hospital for a couple of years now has been to develop more insured business on the off-site platforms where we can grow insured capacity. So, you know, Bordeaux's a lot of our time, attention, and resources right now. Imaging center, and then the clinics there. So that's the sort of bet that we push chips on the table for. Not that we're ignoring the others, but yeah, ER is down this year. It was up last year. I don't know where it's going to be longer term yet. It is a good service, and I can't answer the question, though, as to why. If that was yours, I don't remember. Yeah, sorry.
Thank you. Any more questions on the September financial report? If not, we'll entertain a motion to approve.
So moved.
Second.
Been moved and proper second. All in favor, vote by the sign of aye.
Aye.
All opposed? Ayes have it. Thank you, Bruce. We'll now have a report on our revenue cycle.
The light is green. So I caught that part. Good evening. So just really want to begin by reminding us all together that we have a three-pronged strategy, and it is focused on cash acceleration, net revenue improvement, and Bruce gave us a great example of net revenue improvement when he spoke about the difference between observation and then moving a patient to inpatient, right? So that's net revenue improvement. And then the third is compliance and regulatory type items. And I think we were reminded last time, I know that we were about driving towards a clinically driven revenue cycle. So that's extremely important as it relates to the physician order, and that's driving us to make decisions. Let's talk about cash. So one of our indicators, the top line indicator, is always cash for us. And so September, Bruce said it again, did not shake out in the way that we anticipated, desired. So what we have did is refocused our team on the key performance indicators as a reminder and to develop a tactical type action plan. So while we missed in September, ahead of when we meet and probably next time in January, October and November have both been stronger months. I do want to point that out because that's so essential when you're looking at numbers from September. We can move to the next slide. So when we think about our unbilled days, this is inventory that we've not been able to get to the insurance provider for whatever reason. We stayed flat between August and September. So this is all about education and escalation. What is it that we didn't have? Why did we not have it? And what is it that we need to do about it to ensure that we've got this to the insurance provider and is cycling for payment? So this is part of our contributions or issues related to the cash for September. But again, we've made up for that during the month of October. We can move to the next slide. And so while this says unbilled gross at the top, it's really about denials management. And so denials management is all about advancing the knowledge of our staff to make sure they know what to do, to make sure they know how to do it. We have several initiatives in flight. So when we are denied by the insurance provider, what is it that we're doing? How are we submitting the appeals? Is the appeal timely? So we put together a core team that is strictly focused on educating both our clinical and administrative staff to make sure that we've got that submitted, having the debriefing sessions because that's really important, and then measuring what we are doing. Is that really working for us? And so that's pretty much where we are. I want to share that we're going to continue the fight for every claim, every service that's provided by our clinicians. We want to make sure we collect every dollar. That's extremely important to us. Are there any questions? I think this was the last slide. Yeah. Are there any questions? Happy to respond, share. Otherwise, we appreciate your support. All right. Thank you.
Thank you for your report. We do have 2 contracts that we'll take up at this time.
Okay, the first contract that I'll be talking about is our security contract. We've had our security since the Sheriff's Department left and left us with that contract. And so now we've sent it out to bid. We got our bids back, and the company that was selected was Willems Security. It's a 3-year contract, and you see the total cost there, and the term is 3 years. And so we're looking for approval from the board on that security contract. We were with G4S, who was with the city, and they've changed contracts as well as far as the city has with G4S. And so this contract would give us more flexibility and a long-term outlook with this new company. So that's why we're seeking board approval for change and approval.
Sorry. Dr. Brown, how does this contract compare financially with G4S from a cost perspective over
the contract? So the contract is a little higher than the one that G4S presented back to us, but there's several reasons for that. As you well know, there's a shortage of security forces around the country, and so it's no different with these companies. One of the issues that we have with the previous contract was the amount of pay that they were paying the officers was low. And so then the quality of officer that we get depends on how much they're getting paid and then how we can get those officers in. The other thing that we had with the other company was because they were having problems securing officers, a lot of shifts went without coverage, or people were working double shifts trying to cover it and make the whole. So we felt like if we moved to this company, it would be a lot less of that. And we tracked that, Mr. Galoo in the back of the room, tracked that over time. So he has the numbers and how much coverage that they end up having to do and to provide the services. So when we swapped from the sheriff's office to the current contract that we had in place, it was a learning curve. And that was because they were like really low on the pay. So trying to get trained officers in to do what we do here at our hospital is a little bit different than the rest of the hospital. Our hospital here, our officers have to go hands-on, which means that they have to touch patients. In other facilities, because the officers that are there, like Vanderbilt, are law enforcement, so it's a little bit different. So their security officers there only watch the patients, whereas here they have to go more hands-on, which causes us to pay a little bit more in costs for our officers.
So do you know roughly how this differs, like what percentage higher this particular contract is? I see the officers are $33.89 an hour, but overall, do you know how much more?
I think, if I'm not mistaken, it was, what, Jerry, 22 an hour for...
Allied's current contractor was paying their officers 20. Nashville area is 25. The current vendor, proposed vendor is 22.14.
Thank you.
And can I just because I do see the
Go ahead,
security costs, if they filled all the slots, because that's been a challenge for us, if they fill all the slots of the 23 or whatever FTEs, it would be 110,000 roughly with the current vendor. And so this is more like 125,000. So it's higher, but we were going to probably have an increase even if we kept Allied, the current vendor. The issue is they can't fill all, so we're supposed to have 23 or 27, I can't remember FTEs, Jerry will know. But we oftentimes end up, when we're supposed to have 4 in a shift, we have 3. And, you know, if something bad happens, that reflects poorly on all of us. And so they're not able to get folks in here. And that's part of the reason why, even though they were a bidder, they were probably, one of the ones that we just felt like they could do better, we could do better. And we've had a lot of their officers that are working, I don't want to say 24-hour shifts, but they're working very long shifts because they're so short of people, and that's not safe. I mean, we try to avoid that in our hospital, having anybody work those kind of hours, and it was happening with security occasionally. And so it is a little more expensive. They are going to pay the officers a little more. And we do have armed officers, which
yes.
some of the others don't, and so that's going to always cost a little bit more. So that's my view of what we're trying to do here.
For what it's worth, St. Thomas uses this security company, and they've been very happy with them. Yeah.
Yeah, I heard, Dr. Martin, that they're a really good company, and they also do a lot of more training with their officers, too. So...
Move approval, Mr. Chairman.
Second.
Moved and properly second. All in favor, vote by the sign of aye. All opposed? Ayes have it. Waiting security contract is adopted. We're now on our second contract. You
Okay.
recognize?
Agility. So this is our clinical engineering and biomed contract. We've been with Agility for the past 4 years or so, but we did send it out to bid to get other players, and we end up back with the Agility contract. So pretty much the same when I look at the numbers, maybe a slightly higher cost than what we had before. And so it's a 3-year contract, and we've had Agility for, like I say, the last 4 years here at the hospital. Right now, we took the asset management out of that contract, and so they'll be doing biomed and equipment repair for our imaging department is what the contract consists of. Happy to answer any questions that you may have on that contract.
Thank you.
Move approval.
Second?
All right. Moved and properly second. All in favor, vote by the sign of aye.
Aye.
All opposed? Ayes have it. This contract is adopted. I think we have come to the end of our agenda. Before we close, I have had the pleasure of serving on this committee for several years, and I have enjoyed it. I think we've had some tough financial times and some better financial times, but I want to say to Bruce, I remember when you stepped into this role, it was a pretty tough moment, and I want to thank you for your leadership in handling the fiscal responsibilities of this institution. Particularly at that time when you came on, we were under a lot of criticism in terms of the finances of the hospital and what that looked like. And so you've done a great job, and your team and all of the teams here, and Dr. Webb. So thank you. And I'm saying that this will be, I guess for right now, my last finance committee meeting. And when we get to the board meeting today, we'll make a recommendation for chair. And so, but thank you. With that said, I entertain a motion to adjourn.
So moved.
Moving proper second. We're adjourned.